I do want to thank Dr. Donn for joining us. Professor Emeritus Donn, Steven Donn, is from the University of Michigan. He is also the editor-in-chief at Seminars in Fetal and Neonatal Medicine. He is a staff neonatologist, and as I mentioned previously, Professor Emeritus in Pediatrics at the University of Michigan. Thank you, Dr. Donn, for joining us and sharing today.
Thank you. It's a real pleasure. Well, thank you very much for the invitation to join this group, which I very much look forward to. But I thought for my first presentation, I wouldn't jump into complex science or medicine, and rather have a little fun with something that's been of interest to me, and that's the historical evolution of neonatal mechanical ventilation. And I've been really fortunate because I've been involved in this field for 40 some years, and to have experienced all of the changes that have taken place since I first became interested in neonatal intensive care in the early 1970s, got me to thinking, wonder what happened before I got into this game. And so this lecture is really a labor of love. And here are my disclosures related to the content. Now, why am I starting with a picture of a man walking on the moon, July 20th, 1969? Many consider this to have been at the time the preeminent scientific achievement of mankind. And yet it was kind of interesting that men were walking on the moon before babies were on mechanical ventilators. And got me again to think, I wonder what the journey had been that got us to this point where extremely preterm babies can now be supported by artificial means. Well, the story goes back quite a while. And in the Old Testament, in the book of Exodus, there is a story of the Hebrew midwife Pugh, who breathed into the baby's mouth to cause the baby to cry. Probably the earliest description of neonatal resuscitation. And as a little sidelight, I think this was probably the first neonatal transport, when baby Moses was placed in the basket in the bulrushes and floated down the Nile River. Now, the story really, I think, begins with Hippocrates about 400 BC, who described intubation of the trachea to support ventilation. We jump ahead 500 or 600 years to Galen, who was, of course, one of the first great physicians in history. And Galen inflated the lungs of dead animals using a bellows and postulated that air movements caused the chest to rise. Although that observation was certainly correct, Galen believed that respirations were methods to cool the body, but didn't have any life-sustaining qualities. And I suspect he spent too much time watching dogs pant in the summer heat. Jumping ahead to Paracelsus, who lived from 1493 to 1541, he described the resuscitation of individuals who had presumably drowned using a bellows and an oral tube. So again, a very early description of resuscitation. Andreas Vesalius, a Scandinavian, in 1543 described tracheostomy, intubation, and ventilation to maintain life. And his subject was a pregnant sow. And again, this probably has very remarkable connotations for future perinatal and neonatal resuscitation. In the 1600s, the concept of respiratory physiology began to take shape. And the two men you see pictured here, Robert Boyle and Robert Hooke, were instrumental in describing the fundamental laws of gas pressure and volume. They noted that when placed in a vacuum chamber, larks, sparrows, and mice promptly died, and they recognized that there was something essential for life in the air that we breathe. Now, Joseph Priestley is one of the giants in the development of the concepts of oxygen. Priestley lived in Birmingham in the UK, and in 1774, he produced dephlogisticated air, which subsequently was shown to be oxygen by removing the nitrogen. Priestley further noted that this substance kept mice alive and resulted in a brighter candle flame, but he didn't relate the gas to the process of respiration. Now, a very interesting character in all of this was a fellow by the name of Carl Wilhelm Scheele. He was of German-Swedish background, and he really was the one who discovered oxygen around 1771 or 1772. But he delayed delivering his manuscript to the publisher until 1775, and it wasn't published until 1777, well after the publications of both Priestley and Lavoisier. So his take-home message really is don't sit on your data. If you've done some good research, publish it, because if you don't, somebody else will. Antoine Lavoisier is another really interesting character of this era. And in 1778, he termed this vital gas oxygen. And he understood the role of oxygen in the process of respiration and described its medical implications. But he was a bit of a heretic, and he died during the French Revolution, of all things, acute hypoxia at the base of the guillotine. And the next two gentlemen I'm going to describe, and you'll pardon sort of the unintended pun. The first is a gentleman named Smellie, and the second one is a gentleman named Pugh. But Smellie in 1752, he was a Scottish obstetrician. Many consider him to be the father of modern obstetrics, and he described a straight silver endotracheal tube for resuscitating newborn infants. Dr. Benjamin Pugh also, in this very impressive treatise of midwifery, said that he was to recommend to public practice some instruments and other observations and improvements in the art after 14 years of practice. And he recommended and described the technique of mouth-to-mouth resuscitation, excuse me. And he described an air pipe for intratracheal ventilation. You see the picture of that on the right. A few years later, John Hunter developed a bellows type ventilator with a pressure limiting valve. So this also was probably one of the earliest steps in automated ventilation and pressure limiting. Another early giant in the field was a physician named Francoise Chaussier, who was a professor of obstetrics in the French Academy of Science. In 1780, he gave oxygen to a neonate. He described mouth-to-mouth resuscitation of infants, and he described an intralaryngeal tube for use in infants, and described a means of providing ventilatory support for infants. And you see the picture of these devices on the right side of the slide. Shortly after that, James Blundell came into play. He was an accoucheur or an obstetrician at Guy's Hospital in London. Many of you probably know that Guy's Hospital is still in existence today. He described mouth to trachea inflation using, again, a silver tracheal tube, which he said every accoucheur should carry. And for resuscitation, his recommendations include quick and skillful intubation. He was the first to describe palpation of the umbilical cord to access or assess the heart rate. And he actually recommended the gradual cessation of ventilatory assistance when the infant began spontaneous breathing. And I think, you know, in this period of time, we see the development of a more standardized approach to resuscitation of the depressed newborn. This was an observation that kind of set things back, however, and it was made by Leroy in 1827. And he described an association between positive pressure ventilation and the development of pneumothorax. And like many things that often happen when you get a negative report, many clinicians stopped providing ventilatory breaths, particularly using the bellows device, because of the fear of developing an air leak. Now, let me pause a little bit here and share with you a very interesting and humorous literary anecdote published by Charles Dickens, and it was in the novel Oliver Twist. Dickens, number one, as you'll see, was not a great fan of the medical profession. Number two, he tended to be quite verbose because the style at the time was to pay authors not by the quality of the work, but by the number of words that were contained in the document. Nevertheless, on the very first page of Oliver Twist, which I think was published in 1834, Dickens gave what was probably the finest lay description of maltransition. Let me share that with you. Whoops. My slide has disappeared. Well, let me try to do this from memory. Dickens, in describing the birth, said Oliver was brought into this world, not breathing, poised on a flock mattress with the projection that he was not going to survive. And if in this moment he had been surrounded by anxious aunts, careful grandmothers, nurses, and doctors of profound wisdom, he would invariably and indubitably have been killed in no time. A few years later, a French physician, Gairal, devised the device you see here called the Aérophore pulmonaire, used for intermittent positive pressure ventilation of newborn infants. And it was an all-in-one device that included the endotracheal tube here attached to a bulb syringe through which positive pressure ventilation could be effected. And this device was automated a few years later. The fellow Dwyer apparatus, which was a ventilatory device in which long-term positive pressure could be performed, and was done so in a large series of children, using a foot pedal to control the bellows and having one's hands free to manipulate and care for the airway. In 1889, Professor Egon Braun of Vienna devised a wooden box negative pressure ventilator, which you see here. There was a cutout for the infant's airway and a vacuum box, and using a vacuum pump, the pressure within the box was made subatmospheric, allowing for a pressure gradient to deliver oxygen to the lungs. That same year, Alexander Graham Bell, of course, better known for other inventions, created a negative pressure ventilator. And he modeled this after the cuirass, or a medieval body armor for protecting the breast and back. Now, there's a little backstory to this in that the impetus for Bell's device came from a very tragic occurrence. He lost one of his children to sudden infant death syndrome before anybody understood what SIDS really was. And you can see here his handwritten notes. He developed the cuirass specifically designed for newborn infants, hoping that if there was a way to ventilate these babies, nobody would have to undergo the fate that his child suffered. Now, I'll deviate a little bit here and talk about some adult developments that further led to improvements in neonatal care. And that was the development of endotracheal intubation. One of the earliest proponents of this was Chevalier Jackson in the early 1900s. And he described, of course, the use of the laryngoscope to visualize the airway and allow for direct visualization during intubation. There were tremendous steps taken towards improving the respiratory care that came about from battlefield injuries in World War I. The groundwork for understanding acute or adult respiratory distress syndrome came from observations that were made on the battlefield. And importantly, the development of the modern day laryngoscope, which contained both a battery and a light in its handle and blade, by Henry Janeway in 1913. Two British Army anesthesiologists, E.S. Robotham and Ivan McGill, modified, simplified, and publicized endotracheal intubation. And many of you probably recognize the name McGill associated with the forceps that are used for nasotracheal intubation. Howell Flagg in 1928 described the necessary equipment for positive pressure ventilation by an endotracheal tube, and he used the pressure manometer to actually record the administrating pressure and placement of the thumb over a hole in the tubing to allow for the delivery of positive pressure breaths. Again, probably the forerunner of today's devices, particularly those used in the neonatal delivery room setup like the NeoPuff. And around this time, the debate began to develop, how does one ventilate the lungs? And is it best to apply positive pressure directly to the airway, or are we better to use negative pressure and spare the airway? Well, the evolution of negative pressure ventilators occurred rather quickly in the 1920s through the 1950s. And this is just the series of pictures of devices that were used during this period of time. Again, the idea being that you can ventilate by changing the gradients through surrounding the body with subatmospheric pressure. And it really came to the fore during the polio epidemics of the late 40s and early 50s, with the development of the so-called iron lung, and many infants and children being ventilated for prolonged periods of time in these negative pressure devices. And of course, the major benefit was that it spared the airway of having to be intubated and potentially damaged. At the same time, the development of oxygen therapy for newborns came into play. And the initial strategy was to flood incubators with 100% oxygen to try to keep premature infants alive. And some centers then adapted metal cannulas like you see here, which delivered 100% oxygen once babies had been weaned from the incubator, so that supplemental oxygen could continue to be applied, along with probably some unintended or unrecognized positive end expiratory pressure. About 10 or 15 years later, the observation was made, though, that oxygen's not always a good thing. And Terry, who was an Australian ophthalmologist, reported retinal detachments that appeared to occur frequently among premature infants who had received 100% oxygen over prolonged periods of time. And the pathologic findings of oxygen toxicity, initially termed retinal fibroplasia, are now known as retinopathy of prematurity. And perhaps one of the more famous victims is shown here, Stevie Wonder, whose blindness is the result of retinopathy of prematurity. And of interest to me is he was treated in Saginaw, Michigan. And again, in the pre-neonatology era, he was treated by pediatricians. And I had the good fortune to meet one or two of his treating pediatricians. But again, at a time when the pathophysiology wasn't really well understood. Negative pressure ventilators for newborns probably reached their peak in the 1960s. They began in 1950s under the direction of Dr. Millie Stallman from Vanderbilt University in Nashville, who really made the negative pressure ventilator a very popular device. And again, in this little schematic, you can see there were two chambers, one for the body, one for the head. This was an Air Shields negative pressure ventilator. And I have to confess, I'm old enough to have recalled using this, not as a primary device, but by the time I had gotten involved in neonatal intensive care, this was sort of a bailout device when we had babies who had respiratory depression of some etiology that was non-pulmonary. So neurologic disease, neuromuscular disease, neurologic injury, where the lungs were essentially normal, but the work of breathing needed to be provided. And again, the baby was placed, as you can see here, in this body chamber with a separate chamber for the head and neck. And this device then allowed the cycling of negative pressure, which the clinician could adjust according to the ventilatory needs of the baby. The main problem with this device was it made access to the body rather difficult. And obviously, every time you had to enter the patient chamber, the vacuum was lost and the ventilator wouldn't ventilate. But it played its role, and probably many babies were saved as a consequence of this device. The most famous one was probably the Bloxsom Airlock. This is circa 1950. This was a device that was filled with 100% oxygen and pressure inside the hyperbaric chamber and was cycled at 1 minute intervals. Probably not a very effective device for today's neonatal population, however. In 1953, Ian Donald and Josephine Lord described an early model of a positive pressure mechanical ventilator that was used for prolonged ventilation of both term and preterm infants. And you can see here a little baby inside the ventilator. And this was really the dawn of neonatal intensive care. And on the next two slides, I have some recommended therapies that were used to treat RDS between 1917 and 1965. And some of these seem awfully barbaric. And certainly there wasn't a great deal of an evidence base, but as medicine was practiced back then, if you had a success, you published it, and then everybody tried to do it. The first of these gentlemen was a Finnish pediatrician, Arvo Iplo, who lived from 1887 to the ripe old age of 105. He died in 1992. One of his recommendations was the use of intragastric oxygen, which he published in 1917. And the idea was you insufflated the stomach with 100% oxygen, and either through diffusion or through rebreathing as the gas entered the airway, you could improve the oxygenation of the baby. Other therapies that were utilized included aerosolized streptokinase. I doubt this would ever go through an IRB today, but the idea back then was these so-called hyaline membranes could be dissolved using the enzyme streptokinase. So give it directly into the lung and get these membranes dissolved. Hyperbaric oxygen was another treatment, which you saw before. The Usher regimen, this was a very interesting observation. Bob Usher was kind of a first generation neonatologist. He practiced at McGill University in Montreal, and he developed a regimen in which an intravenous infusion of glucose and sodium bicarbonate was given to preterm babies with respiratory distress syndrome. And the rationale here was that a lot of these babies developed hypoglycemia, so you treated that with the glucose. But the use of bicarbonate was primarily to offset the acidosis that many of these babies developed. Unfortunately, in most instances, this was a respiratory acidosis, and the use of bicarbonate actually made a bad situation worse by creating more carbon dioxide that the baby had to ventilate. Well, he did have some preliminary success with this. So he came back with a modified Usher regimen in which he increased the concentrations of both glucose and sodium bicarbonate. And the net effect was a very, very large incidence of intracranial hemorrhage in babies that were treated with this. So as quickly as it came into practice, it disappeared even more quickly. Epsom salt enemas, and I'm sorry, I can't give you any potential mechanism through which this would treat respiratory distress syndrome. Alvair, a detergent mist. This was sort of a forerunner of surfactant therapy when the observations were made that surfactant was a detergent-like product. This product was attempted. Rocking beds, some of you may recall, these were used quite frequently to treat apnea of prematurity. And the idea was automating the process of stimulating a baby to breathe when he or she was apneic. As an aside, I don't know how many of you remember the first and second generation neonatal incubators, but all of these had a circular hole at the top of the incubator. And people often ask, why was that hole present? For a couple of reasons. Number one, it seemed to always show up right in the center of the lung fields when you took an X-ray as a perfectly circular lucency. The actual reason that it was put in, though, was to allow suspension of a scale. So babies are actually weighed by placing the scale within the incubator and then holding it up through the hole in top of the incubator. Well, one bright nurse probably came up with the idea that, you know, if you put a string through that hole and attached it to the infant's toe, every time the baby got apneic, you would just have to tug on the string and the baby would breathe again. So we made a big jump with the rocking bed. Something that I was first trained on in the early 1970s was withholding of fluid and nutrition for the first 3 to 7 days of a baby's life. And the idea here was you could possibly force them to absorb the excess pulmonary fluid they were born with and maybe resolve either transit tachypnea or respiratory distress syndrome by withholding fluid. And finally, something that I shudder to this day, the concept of sternal traction. And here you see one of the hallmarks of a newborn with severe respiratory distress are subcostal and intercostal retractions. And somebody postulated that you could put a hook into the sternum, and by pulling up on it, you could improve lung volume and functional residual capacity. Didn't catch on really well, thank goodness. About the best application of this came from the movie A Man Called Horse. Some of you may recall, where as one of the rites of initiation, poor Richard Harris was suspended by hooks that were placed in his breast tissue. Now we go into the sort of modern era of neonatal intensive care. And I hope some of you had the pleasure and the honor, as I did, of meeting Forrest Bird, who is really maybe the biggest giant in the field of neonatal respiratory care. And he was a phenomenal person, as well as an inveterate gadgeteer. During the Second World War, he developed a real interest in respiratory physiology of aviation. And he flew his own plane, and he adapted many of the principles of high altitude respiratory function in the workshop that he developed in his garage at Sandpoint, Idaho, and developed this modification of the adult ventilators, the Bennett PR2 and the Bird Mark 8 ventilator, which he's holding in his hands here. And he modified these so that they could be used in newborn infants. And many of you are probably familiar with the baby bird ventilator, still being used in many parts of the world. I'll show you a picture of it later. Now, as we got into the 1960s, the first reports of positive pressure ventilation in premature infants reached the medical literature. And probably the landmark article was published by Paul Swire and Maria Delavoria Papadopoulos, who were at Sick Kids Hospital in Toronto, reporting some success using the Bird Mark 8 ventilator. Maria was a phenomenal neonatologist. Sadly, she just died a few months ago. She lived to a very ripe old age and was still active just before she passed away. And I think this picture came from the article that they published in 1963 showing a preterm baby on a mechanical ventilator. Now, this is a really, by today's standards, pretty good sized preemie, probably 33, 34 weeks, weighing about 2 kilograms. And that number becomes very, very significant as it relates to what I consider to be the birth of neonatology as a recognized subspecialty in August of 1963. And why did that happen? In August of 1963, John Kennedy, who was president of the United States, and his wife Jackie gave birth to their third child, a premature infant, Patrick Bouvier Kennedy, on August 7th. Patrick was born at 34 weeks gestation. He weighed 2,100 grams. He developed very severe RDS, which was treated with hyperbaric oxygen. He had been transferred from a hospital on Cape Cod to Boston Children's Hospital. He was under the care of Dr. Mary Ellen Avery, who was one of the first preeminent neonatal pulmonologists. Patrick became severely hypothermic, and unfortunately, he died at 2 days of age. His medical records are still sealed. And, it's phenomenal to put this case in context. It's about almost 58 years since this happened. And I keep thinking, what if this had happened today? Well, Mrs. Kennedy would have been given steroids, perhaps a tocolytic, and if stable, rather than transferring the baby, she would have been transferred to a maternity facility with a level 3 NICU. Patrick's RDS would have been treated with either CPAP, plus or minus surfactant and mechanical ventilation, and he would have had a predicted survival of 90 to 95%. I can't share with you the exact reason for why the medical records are sealed, but I have heard from many reliable sources that this was a political decision, that it would have looked extremely bad if the United States had to transfer the offspring of its president to a foreign country for respiratory management. So I guess someday we will learn the truth. It didn't take long to go from describing respiratory distress syndrome to describing bronchopulmonary dysplasia. And as you're all aware, this is the primary chronic form of respiratory disease in newborns. And interestingly, its first description did not come from a neonatologist. It did not come from a pediatrician. It did not come from a pediatric pulmonologist, but rather it came from a pediatric radiologist, Dr. Bill Northway, who is still alive today, a very wonderful person. We published an issue of seminars on bronchopulmonary dysplasia, and I convinced him to write the foreword for the issue because he played such a dramatic role in promulgating information about this. And he published an article with his colleagues in 1967 in the New England Journal of Medicine, describing a group of babies, kind of first generation survivors of neonatal mechanical ventilation. And these were term, or as we called them back then, near-term infants who had been exposed to high pressure and high concentrations of oxygen. You can see how the X-ray shows overinflation, severe cystic emphysema, and fibrosis of the lung. And on histopathology, the lung showed interstitial and alveolar edema, small airway disease, extensive inflammation, and fibrosis. And even though it's been 55 years since this observation, BPD continues to be a baffling, confusing, and very frustrating disease for neonatologists and pediatric respiratory therapists and pulmonologists. Why did it happen? And there were a lot of reasons that were suggested during the early phases of BPD. Adult ventilators only had positive pressure flow during the ventilator breath. In other words, they could not provide end expiratory pressure, leading to the collapse of alveoli at the end of expiration and the requirement for high pressures to re-expand them. And this constant opening and closing of alveolar units led to the process that resulted in ventilator-induced lung injury and chronic lung disease. And in addition, if infants did not breathe in synchrony with the ventilator, they would often rebreathe the exhaled gas. So it made taking care of them that much more difficult. So we moved to trying to find alternative methods for treating these. And you know, this is probably the most famous pendulum in neonatal intensive care. In the early 1970s, a good neonatologist did everything that he possibly could to try to keep the baby off a mechanical ventilator, which at that time was considered to be almost the sine qua non for you're going to die. And so CPAP arose as a potential alternative for the treatment of babies with respiratory distress syndrome. The credit for developing CPAP as a neonatal tool rests with George Gregory's group at the CVRI at the University of California, San Francisco. And around 1970, they published a paper describing the use of continuous positive airway pressure to treat the collapsed lungs of babies with respiratory distress syndrome. And the original device, very simple. the expiratory limb immersed in a tube of water to provide the end expiratory pressure, and a manometer to measure the pressure, and an anesthesia bag to deliver it if you needed to give positive pressure breaths. And this evolved into much more complex and difficult to use devices. Now, while there's no question that this group was instrumental in promulgating the use of CPAP, they are far from the ones who developed it. In fact, the original description of CPAP dates back to 1914 to a German pediatrician named von Reuss, who published in his book, Diseases of the Newborn in 1914, a description of CPAP to resuscitate newborn infants. And in his book, there was this little pen and ink drawing, which you can see the oxygen tank, tubing that's attached to a mask or a rubber ball, and a water bottle into which the tubing is placed to provide CPAP. And if you just think ahead about 100 years, this looks like a typical bubble CPAP device of the 21st century. And the golden age of CPAP, the 1970s and early 1980s, saw the development of all different types of equipment and interfaces. Here you see a number of nasal interfaces that included short and long nasal prongs, single prongs, biprongs, etc. And a number of different methods used to apply the CPAP to the baby, including the use of nasal prongs, as you see here, placement of the baby into a pressurized head box, and a combination of the two. Here's another schematic. One of the hardest things that we tried to accomplish then was to get a good seal and fixation so that we were able to maintain continuous positive airway pressure, even though the baby was moving and breathing spontaneously. This is kind of an interesting picture. I often tell people that it gives a whole new meaning to the concept of bagging the baby. So the pendulum began to swing back towards mechanical ventilation in the mid-1980s. And we began to look at a number of complications that we saw with CPAP, including babies who often fought the stiff nasal prongs. There were reports of a high incidence of air leaks. CPAP belly was reported, which was distended stomach. You know, remember that when you're delivering nasal CPAP, it's non-selective, and a certain portion of delivered gas is going to go down the gastrointestinal tract. It didn't help much if babies were retaining carbon dioxide as their major gas exchange deficiency. And alarmingly, there was a fairly high incidence of cerebellar hemorrhage being reported. And this was felt to be related to the way that the CPAP devices were being affixed using sometimes a mask or a strap that went underneath the baby's occiput and placed undue pressure on the back of the skull. So again, we moved back towards, the other thing that happened during this period of time was that we were doing a better job of saving smaller and more preterm babies. So we had this very large population now that were sicker than the typical CPAP babies of the late 70s, early 80s. So intermittent mandatory ventilation became now the standard primary therapy of treating these babies with RDS. And here we have a use of a continuous flow of gas via the ventilator circuit with an interspersed T-piece. And again, when you occlude the distal end, gas flow is diverted to the patient. And by mechanizing this with an exhalation valve, we have the first mechanical IMV device made for specifically for babies. So when the baby would take his own breath, he would receive a fresh source of humidified gas, so the rebreathing issue was solved. Closing the expiratory valve would give mandatory breaths at designated rates, and positive end expiratory pressure could be given, helping to prevent atelectasis. Still rudimentary and not without its problems. I introduced you to Forrest Bird a while back. Another real giant in the field of neonatal respiratory care was Bob DeLemos, somebody that I had the good fortune to know fairly well. And Bob, in combination with Forrest's development of the baby bird ventilator and Mr. Kirby, who was a respiratory therapist, published a series that came from Wilford Hall Air Force Base in San Antonio. And this device became the preeminent neonatal ventilator for many, many years. A very simplistic time cycle pressure limited ventilator with a blended oxygen source with very few moving parts. And, the good news was they lasted forever. And the bad news was maybe it hindered some improvements in design because it was so effective and because it had so few deficiencies in terms of its structure. But we did ask the question about why do we need better methods of providing ventilatory support to premature infants? Well, again, the population was changing. Infants with RDS were still dying. Air leaks were still occurring. And again, there was an unacceptably high incidence of bronchopulmonary dysplasia in surviving babies. And this, I think, led to what I like to think of as the golden era of neonatal mechanical ventilation. 1990 to 2005. And there were so many technological advances that occurred in this relatively short period of time that it would take me all night to go into them, but I just want to highlight a few that I think really revolutionized the field. Again, as I said, the demographics had changed dramatically, and you see now babies of 23 and 24 weeks gestation, weighing 450 or 500 grams, having survival rates that approached and then exceeded 50%. This is the chest x-ray of a premature baby with RDS. And you can note the overall atelectasis, the decrease in lung volumes, and the air bronchograms. And during this period of time, I think the most important realization was the understanding of the pathophysiology of respiratory distress syndrome. And we know that an air-filled sphere, for instance, in this case, the alveolus, is coated with a film of water that has a tendency to collapse. That is, it makes the alveolus reach a minimal volume because of the pulling force of the surface tension of the water. And it became evident that the problem for these babies was progressive atelectasis. Well, along came surfactant, probably the most studied and beneficial drug in the history of neonatology. And what happens with surfactant, you see here in red, the surfactant lines the alveolus on top of the aqueous layer. In other words, it collects at the air-liquid interface and lowers the surface tension, which allows the alveolus to be expanded. And so we go from this collapsed terminal bronchial and alveolus, which prohibited the successful entry of gas during inspiration, to a now adequately expanded alveolus in which oxygen could flow in easily and expiratory gases were able to escape during expiration. This is a photomicrograph showing the pathology of hyaline membrane disease as it was originally called. On the left side is a light microscopy showing atelectasis with this formation of the eosinophilic hyaline membranes that partially lined the air spaces and gave the disease its original name of hyaline membrane disease. And then as the story unraveled, this is an electron photomicrograph of a type 2 pneumocyte. And this cell is missing most of the lamellar bodies, which is the part of the cell in which surfactant is synthesized. And so it became apparent that one of the hallmarks of this disorder was surfactant deficiency. The exogenous surfactant story is really a phenomenal one, and particularly with how long it took from getting the realization that surfactant deficiency was the hallmark of RDS until the product finally came to market. And there were so many individuals that played a role in this that it's really phenomenal. But a hats off really to the neonatology profession as a whole, that the number of published studies that were in the literature in a very short period of time included more than 20,000 infants with an incredible complete data set for about 95% of them. And I'm sure this led to FDA approval fairly quickly. This picture is kind of worth 1,000 words. Here you see a control animal who is surfactant deficient. And again, you see the collapse of the air spaces with inflammatory cells. And this is a surfactant treated animal with a nice reticular pattern of the alveoli with very robust air spaces. And again, pictures being worth thousands of words. A pre-surfactant treated baby, showing again the nearly complete atelectasis of the lung with the air bronchograms, and following treatment with surfactant, the lung is now fully expanded and aerated. The other big breakthrough that occurred during this period of time was the evolution of the continuous monitoring era. And we went from a period in which assessments of babies included once or twice a day x-rays, 3 or 4 times a day blood gases, no way of knowing what was happening on a breath-to-breath basis or a minute-to-minute basis, to the development of tools which allowed us to do exactly that. Transcutaneous gas measurements, first PO2 and then PCO2, and eventually the combined PO2, PCO2 electrode. The development of pulse oximetry, allowing us to have non-invasive continuous monitoring of oxygenation. End-tidal CO2 monitoring, still not a routine, but something which I'd like to see incorporated more in our ventilated patients. And importantly, something which I had a really fantastic involvement in is the development of real-time pulmonary graphics, which I think really revolutionized our understanding of patient-ventilator interactions in the neonatal period. And as you can see, I've had an interest in pulmonary graphics ever since I was a kid. No, this one's not. Okay. So let's talk a little bit about positive pressure ventilation and its role in managing neonatal respiratory diseases. As I mentioned earlier, the very first device was only able to provide intermittent mandatory ventilation. And I like to call this not only intermittent mandatory ventilation, but independent mechanical ventilation, because it really dealt with 2 separate systems. It dealt with a ventilator, which provided breaths according to what the clinician wanted the baby to get. And it also included, oh yeah, the baby who breathed on his own whenever he damn well pleased. And this was a setup for asynchrony. where the spontaneous breaths of the infant were out of phase with the mechanical breaths, resulting in very varying tidal volume deliveries and all sorts of problems that could arise from dysynchrony, including elevation of intracranial pressure and the development of intracranial hemorrhage. It was also not an efficient way to exchange gas, and you can tell from this graphic that any time that the baby and the ventilator synchronized the baby's breathing with the ventilator, we were witnessing a random event. That more often than not, the baby may be trying to breathe against, maybe trying to exhale against incoming positive pressure. And you can imagine how inefficient a system this really was. It often resulted in having to really crank up the ventilator to capture the baby, or to use sedatives or even paralytics to avoid dysynchrony. And so during this time, the rationale for patient-triggered ventilation became apparent. We wanted to optimize patient ventilator synchrony, prevent the fighting or bucking of the baby in the ventilator, reduce the duration of ventilation, avoid undesirable respiratory or cardiovascular consequences, and to decrease the need for sedation or paralytics. And during this period of time, we saw the evolution of patient-triggered ventilation, including the development of synchronized IMV, assist control, and pressure support ventilation. We were about 10 or 12 years behind our adult colleagues in doing this. A lot of it the result of technological limitations, but more importantly, we also had physiologic limitations based on the small size of the baby and the fact that we deal with a nonverbal population and are completely responsible for obtaining feedback in odd ways. I had the very good fortune at this time to become associated with the forerunner of Vyaire Medical, which was Bird Medical Products. And working with the engineers at Bird, they approached me about trying to evaluate a flow synchronized system, a flow triggered system. And they told me that they had developed a flow sensor and a device that should enable flow triggered ventilation in babies as small as 500 grams. Well, it took me about 3 minutes to stop laughing. But then I said to them, you know, if this works, it could change the landscape completely. And the first attempt was with synchronized intermittent mandatory ventilation. And as you all know, SIMV involves timing windows, and if the patient breathes and exceeds the trigger threshold within the timing window, the ventilator will synchronize the onset of inspiration to the onset of the patient's breath, and at least synchronize the onset of inspiratory phase, and hopefully prevent stacking of breaths. But it wasn't enough, and the problem was that during these spontaneous breaths, the only support that the baby was getting was from whatever level of PEEP the clinician had dialed into the system. So we worked on this flow-triggered system to develop assist control ventilation. And in the assist control mode, each time a spontaneous breath triggered the threshold, a mechanical breath would be delivered that was very closely synchronized to the onset of the patient's breathing. And by using an expiratory trigger, we were able to also synchronize expiration and finally have a direct one-to-one synchronization between the baby and the ventilator. And it was clear that this was really a superior way to ventilate very sick babies. It decreased the work of breathing, it decreased respiratory complications, it decreased length of stay. Now, at the same time, high frequency ventilation was beginning to take hold in the neonatal and intensive care unit. And again, a number of eminent individuals were involved with the development and the implementation of high frequency ventilation. Ventilation that's typically done at greater than 150 breaths per minute. And typically with oscillatory devices, we're using rates that are between 7 and 15 hertz. The tidal volume that's delivered during high frequency ventilation is at or close to dead space, maybe even less than that. Hopefully it enabled the easier elimination of carbon dioxide with the avoidance of trauma to the lungs, and perhaps enabled better recruitment of lung volume. Gentleman here is another good friend of mine, Dr. Bert Bunnell, who developed the light pulse high frequency jet ventilator. And again, we were very fortunate to be one of the alpha test sites when this device was brought into the neonatal intensive care unit. And the high frequency oscillatory ventilator, again, a key figure here was Bob DeLemos, whom you met earlier, working with sensor medics. This was the prototype device which Bob used at the baboon colony at the Air Force Base in San Antonio. And eventually this device morphed into what is seen here, today's Sensor Medics 3100A. You know, an interesting disease entity that was very baffling arose towards the end of the 1960s. This was initially called persistent fetal circulation. It was first described by the group at Babies Hospital, Columbia University. Bill Gersony, who was a pediatric cardiologist, working with a number of the neonatal people there. And what they described was a disease entity in which babies were profoundly hypoxemic, but had clear lung fields. And they dubbed it persistent fetal circulation because there was right to left shunting that occurred through the fetal channels, the patent foramen ovale, which was a flap window between the two atria, and the ductus arteriosus, which connected the pulmonary artery with the aorta. And in utero, these are wonderful because they enable the fetus to bypass the systemic circulation and send blood to the placenta, where it's oxygenated and where waste products are removed. But once the baby's born and no longer has the benefit of the placental circulation, right to left shunting results in bypassing the lungs and in profound hypoxemia. And this disease was incredibly baffling. Many of us went through a learning phase where these babies would come into the NICU and they would go down the inexorable path of deterioration and die. And we would swear, gee, they must have had cyanotic heart disease because the lung fields were clear. They'd go to autopsy and the pathologist would call and say, the lungs were completely fine, the heart was completely fine. I have no idea why the baby died. So it took the better part of the next 15 years to kind of unravel this. And again, we began to focus on the pathophysiology, noting that some babies have increased reactivity of pulmonary vasculature, where they constrict and decrease pulmonary blood flow. Some have structural alterations in the pulmonary vasculature. And the net effect is that there is elevation in pulmonary vascular resistance with diminished pulmonary blood flow and right to left shunting. This gave rise in the early 1980s to extracorporeal membrane oxygenation as sort of the ultimate bailout, in which bedside cardiopulmonary bypass was provided as a means of support and to provide heart and lung rest while the baby recovered. And again, I guess time and place are everything. I was very fortunate to work in the center where Bob Bartlett brought ECMO to the neonatal world. And we had an enormous ECMO experience at the University of Michigan. This is just for those of you that may not have seen it, this is a bedside bypass. This baby is actually receiving venous ECMO with a single catheter with multiple lumens for venous blood, which drains passively, and then arterial blood or oxygenated blood returning from the membrane oxygenator to the baby through the same catheter. And we learned, again, ECMO had a learning curve as well. One of the initial difficulties was lung management during ECMO. Many of the babies on veno-arterial ECMO developed a whiteout on the second day, and various therapies were attempted to try to alleviate this and expedite the course of ECMO, including the use of diuretics and also using high CPAP to try to force the edema out of the lung. Once again, a drug appeared that changed the game dramatically, and that was inhaled nitric oxide. This was an agent that was administered through the ventilator circuit as a selective pulmonary vasodilator. The really beautiful part of this was it really had no systemic side effects and was able to, in many instances, reverse the pulmonary hypertension and enable us to treat babies without having to resort to ECMO. And again, this is just a little schematic that exogenously administered nitric oxide works the same way as endogenous nitric oxide. It diffuses across the endothelial cell. It causes relaxation of these endothelial smooth muscle cells and allows for improvement in pulmonary blood flow. The nice thing is that it's almost immediately inactivated as soon as it combines with hemoglobin, which is why we can avoid the systemic side effects that other drugs have been associated with. The one trick with nitric oxide, though, was we needed to successfully recruit the lung. That if you delivered nitric oxide to areas that weren't being adequately ventilated, it certainly wasn't going to work. And finally, the other thing that came along during this period of time, which has subsequently fallen by the wayside, was liquid ventilation. Probably first made popular by this movie that surfaced, I think, at the end of the 1980s, called The Abyss, in which liquid ventilation was used to support a diver. This compound called perfluorine is the medium through which liquid ventilation was attempted. This is a high molecular weight compound that is that has very high oxygen solubility and a high specific gravity, but is otherwise relatively inert. And it was administered through the endotracheal tube into the lungs. And there were two ways of treating it, either partial or total liquid ventilation. With partial liquid ventilation, you just continue to ventilate the baby using this medium as the exchange. With total liquid ventilation, like an ECMO circuit almost, you continually cycled oxygenated perfluorine. And there was some preliminary success with this in babies who had intractable respiratory failure, either from RDS or congenital diaphragmatic hernia. But somewhere along the way, there must have been either a complication or a warning, because Alliance Chemical, the company that makes this, and this is not a medical drug company, but a commercial company, pulled it off the market and said, we don't want the medical liability. So it kind of disappeared from the scene. Well, again, neonatology is a moving pendulum, and that pendulum has now swung back to the rediscovery of CPAP as well as non-invasive ventilation. And this really occurred in the late 1990s after the surfactant era had come and been well established. And I think part of the reason for this, again, related to a high incidence of chronic lung disease, but also a change in obstetrical practice. And now the use of antenatal corticosteroids has become almost universal in the United States and the Western world. So babies, particularly babies between 26 and 34 weeks gestation, have much less RDS or much less severe RDS and can be successfully treated with non-invasive means. Well, that's kind of where we are today. Is this a rising sun or a setting sun? I hope to think it's rising, as we're continuing to evolve newer, better, and less dangerous therapies. Our population has pretty much stabilized. I don't think we're really going to get much below 23 weeks survival. And hopefully now we're at the point where the morbidity will catch up with the mortality. And usually what's happened in neonatal intensive care has been that when a breakthrough comes through, the first thing we see is an improvement in mortality, only to realize that there were morbid side effects that we hadn't considered and needed to address. So I think that's the path that we're on right now. So let me stop here, and hopefully I've entertained you if nothing else. But if you do have any questions, I'll be happy to try to address them.